learn a little bit about some of the advances in stroke therapy and how incredibly related they are to cardiac care. We have basically two comprehensive stroke centers, one at Washington Hospital Center and then one at Georgetown University. And I don't have any financial disclaimers, but I have a lot of people to thank on the team. Here's a few of the members of the team. Amy Shai is our stroke neurologist, director of the NIH stroke team at Washington Hospital Center. And over at Georgetown University, Andy Stemmer is our director of stroke neurology and interventional neuroradiology at Georgetown. He's accompanied by Mike McCullough. And then my other colleagues include I.C. Liu, who's one of our neurointerventionalists here at Washington Hospital Center, as well as Dr. Jeffrey Mai, who's also a neurosurgeon trained in neurointerventional, as well as Dr. Daniel Fehlbaum, whose login I am actually currently using right now. So I'm signed in as Dr. Daniel Fehlbaum, but he's a much more energetic and younger version of myself. This is one of our former fellows who's in Saudi Arabia right now, Saeed Al-Qahtani. And this is an essential member of our team right here. This is Leslie Martinez, who's been doing neurointerventional with different members of our team for the past 25 plus years. We also have a collaboration with the military. We work with Walter Reed attendings to include Dr. Randy Bell, who helps us cover neurointerventional work at Washington Hospital Center, and also assisted by other neurosurgeons to include our department chief here at Washington Hospital Center, Dr. Eddie Alisi, and my Navy colleague, current civilian, is Dr. Brian Mason, who we had trained together in medical school and at Walter Reed together at Navy Bethesda, and he continues to support us from the neurosurgical end. So it takes a team. What I want to emphasize is that although we're dealing with occluded vessels, both in the realm of stroke as well as in the realm of cardiac dysfunction, they tend to be different types of occlusions. So the occlusions that we typically see for stroke tend to be embolic. They tend to come from either the carotid artery, the aortic arch, or the heart itself, whereas those within the coronary circulation tend to be thrombotic. So if you think about an embolic stroke coming from the heart, it usually is either platelet-rich or more commonly red blood cell-rich. And those within the heart itself tend to be a disruption of this plaque that occurs within the coronary artery. So it's usually the formation of a plaque, the complex lipid profiles that basically change, causing ulceration of that plaque. And it has different characteristics in terms of its composition of platelets and its underlying intracranial atherosclerotic, or excuse me, its coronary atherosclerotic disease. So these are more atherosclerotic lesions. These in the brain tend to be more soft plaques. The other important thing to understand is that the vessels of the brain have a different consistency. They have a much smaller muscular layer, and they don't have an external elastic membrane, and they're not attached to a muscle. They're attached basically very, very loosely to a web known as the arachnoid space and the subarachnoid space. And so in this space, they have a variable amount of movement. They tend to be much more fragile as a result of their composition and location. The vessels that we talk about for thrombectomy are these large vessel occlusions: the carotid artery in the brain, the middle cerebral artery of the brain, the proximal portion, or the basilar artery in the brain. We don't usually go after the much smaller vessels, which are out in the distal circulation. We'll talk more about that later. So when a clot occurs, basically there's an occlusion of blood flow, and there's a tissue then that's at risk. Part of that tissue becomes ischemic with irreversible injury. We call that the core. The other part of that is at risk for further ongoing cell death. And the way to think about this is that basically the clot is impairing blood flow and nutrients, causing a cellular change which impairs the ability of the cell to function. So the cell can no longer maintain its membrane. There's an influx of calcium. The brain cell swells and then dies. Now, because of the collateral circulation, there's a variable amount of time that we have between a blood clot causing a a permanent stroke and causing what we call reversible ischemia or penumbra. So the penumbra is that portion of area of tissue at risk that we're trying to reverse. So this comes down to an important real-world philosophy in terms of it's a tissue clock, not just a pure time clock. So it depends upon this collateral circulation, as shown here, from the middle cerebral artery connection with the anterior cerebral artery. So this sort of junction of the two circulations that try to bring blood flow to the penumbra until we can remove this clot. So in acute ischemic stroke, we're looking at the role for IV therapies, typically IV TPA, and that can be administered now within 4.5 hours from stroke onset. Although many of the patients who are cardiac patients are not eligible for this because they're on concomitant anticoagulation such as Xarelto and other agents, or they've had recent cardiac procedures. And then we look at the role for endovascular thrombectomy. In endovascular thrombectomy, we try to do as fast as possible, although we can do it in some cases in a delayed fashion because of patients who present for a delayed fashion, but we never delay thrombectomy. It's never like we want to wait until 6 hours. It's always the idea of the sooner the better because there's ongoing tissue loss, brain damage that's occurring. Depending upon the collateral circulation, there might be some cases where we can do this up to 12 to 24 hours, and we'll talk a little bit about those studies. But the majority of the cases we try to do in under 6 hours and as soon as possible. The other important thing to understand about these therapies is that we don't do one or the other. In fact, what we'll do is we'll do both at the same time. We'll start the IV therapy while we're prepping and doing the thrombectomy. So we don't wait for one to work before we proceed to the other. We actually do them in parallel. So if a patient's getting IV TPA, it doesn't mean that they're not a candidate for mechanical thrombectomy. It means that, in fact, if they show evidence of a large vessel occlusion, we'll do the large vessel occlusion while they're getting the IV TPA is the important thing to realize. The techniques of this have been revolutionized by the use of a stent retriever and different aspiration catheters that we can now direct all the way from the groin or radial axis all the way up into the intracranial circulation. And this basically is built on sort of a tower of power kind of concept of one catheter inside of another catheter inside of another catheter that gives you the proximal support so that then you can navigate these much smaller microcatheters up into the circulation to then deploy your stent retriever and grab a hold of the clot. We'll show you an example of that here in the next little video. This is a little video that's provided by the aspiration company that makes the catheter. So this is a clot in the middle cerebral artery, for example. And then this is sort of a demonstration of getting groin access, moving the guide catheters from the groin access up the arch of the aorta, and then selectively up into the carotid artery. Of course, you never have a patient whose vessels are that straight or clean. And then up into the intracranial circulation where we deploy the microcatheter, and in this case, direct suctioning of the clot. So this is called the ADAPT technique or no-touch technique, where we're just suctioning on the clot itself and not using a stent retriever. So the idea here is that this suctioning prevents this clot from being broken up and embolizing to non-target vessels. And this all works well in about 30% of cases where we don't have to do further revascularization procedure. But if the clot is very adherent, more platelet-rich or fibrin-rich, then usually in those cases we have to use a stent retriever. The limiting factor has to do with getting this particular aspiration catheter to target. And due to the tortuosity that we may be encountering, that becomes the biggest obstacle. So we'll go to another demonstration of, this is a demonstration now of the stent retriever technology. So the stent retriever looks basically like a small stent. The idea is that it's deployed through a microcatheter. It then engages into the thrombus itself. And the idea is that this stent basically expands and sticks to the thrombus so that when that's being pulled back, you have thrombus capture. So it's not necessarily direct aspiration. We sort of combine these two. We don't use a balloon guide catheter anymore. We've gotten away from that. It's usually too stiff, but we usually use our aspiration catheter right next to the stent retriever to try to aspirate the clot as the stent retriever comes back. One of the problems recently, though, is that a lot of this technology is evolving and is changing quite fast, so that certain stent retrievers we're finding are not necessarily compatible with different aspiration catheters. And the goal, the race, it's like an arms race to try to make more flexible, more navigable catheters has also led to some of these catheters becoming much more fragile. We've had some cases where these catheters have actually unraveled and actually delaminated because of the fragility of the catheter tips. So that's basically, when we look at the studies to demonstrate the effectiveness of stroke therapy, we've seen 4 major studies that are now up to 6 major studies since 2015 for the role for thrombectomy. This compares the number needed to treat, which is as low as 2.5 to 3 for one important outcome, positive outcome. That compares to, on the average, about 17 number needed to treat for percutaneous coronary intervention. And this is not just driven by time. These further studies have been driven by basically what we call a tissue clock, or imaging of the core, as you see in pink here, the dead tissue versus the penumbra. And we'll go into some of those details here shortly. So if you think about the tissue clock, what we're talking about here is that if you have an area of dead tissue, which is small here at the beginning of the onset of the clock, as the collateral circulation becomes more impaired, more tissue dies off. So you go from a large green penumbra to a much larger red volume, to the point where you now have no mismatch. The core equals the perfusion abnormality, and there's no salvageable tissue. So to the far left, early in the time, there's a much larger area of tissue that you can preserve, whereas as time becomes more delayed, there's more completion of the infarct and less tissue that you can rescue. So this all has to do with individual patients' variability. There are some patients who, if they have a stroke right in front of you, despite you opening up the vessel, they may not benefit because they have no collaterals. Their core equals the perfusion abnormalities, where that would be sort of a scenario A. So they have basically large infarcts, severe deficits. You don't want to open up that vessel, because if you open up that vessel in that category of patients, you're going to create a brain hemorrhage. Whereas then there's the other group of patients on the far end of the spectrum, let's say a patient D, who has multiple collaterals that go to that area, and they can actually undergo reperfusion in a later fashion. So they can actually tolerate longer periods of ischemia. But we never know what someone's collaterals are like. So the patients that we usually find ourselves taking care of are those between B and C, where they have collaterals, but they're rapidly failing. They go from a severe deficit, severe paralysis, severe aphasia, severe hemi-neglect, but they have a lot of tissue at risk, so they could benefit. The other group is those that have, again, significant deficits as well, but their collaterals are slowly failing, not nearly as quickly. So you don't necessarily, you're not able to distinguish these two groups, B and C. So that's the reason why time is always of the essence in terms of rapid identification, rapid triage and imaging of these patients, and then the techniques of rapid intervention. And this has been proven before in earlier studies from 2013 through 2015 in what we call the Cadre curve, where they saw that for every period of 30 minutes loss, there was basically a 10% loss of return to independent function. So this was back when we were looking at intervening on patients within a 6-hour window, and that 6 hours usually correlated to about the 50% mark of return to good clinical outcome. But again, that varies now depending upon collaterals and tissue imaging. The other important thing is to understand not all patient circulation is the same, and the idea of where the stroke is has significant consequences. Whether that stroke is in an area of a non-dominant frontal lobe is very different than if it's in a dominant frontal lobe that's responsible for speech, or if it's in a smaller vessel that is not necessarily a candidate for thrombectomy, but is associated with a significant paralysis, as in the internal capsule. So real estate matters quite a bit here. So if we make a comparison here now between revascularization of heart versus revascularization in the brain, we can summarize that in the heart, most of the time, there's underlying atherosclerotic disease. In the brain, it's mainly embolic. If we look at the clinical picture, both have an acute onset, but in the brain, the patient's going to manifest with impairment of neurologic function. And the acronym that we'll talk about is FAST and BFAST, having to do with focal abnormalities in terms of movement of the face, arm, leg, speech, and the need for rapid time. And the BFAST part of that is also balance and eye movement. And we'll repeat this again. The effective therapy is reperfusion therapy, but in the brain, reperfusion therapy can lead to hemorrhage if, in fact, there is a complete match between the penumbra, which is tissue at risk, and the core. So if there is a significant volume of the core, then that increases the risk of hemorrhage. This has changed now in terms of the timing of our window. Again, I just want to emphasize this is tissue dependent. So it used to be a much smaller window where we could use IV agents, IV TPA, in 3 hours or less. But now IV TPA can go up to 4.5 hours, and thrombectomy can go anywhere up to 12 to 24 hours. But again, realize that earlier you go for thrombectomy when you have tissue at risk, the better your outcomes are going to be. The other important thing is that there's a marked undertreatment of thrombectomy. This has to do with several issues. One is because the establishing systems of care where EMS is bringing those patients directly to the units that have thrombectomy capable revascularization, as well as patients themselves are trying to avoid going to the hospital, especially in this time of COVID. This is most pronounced, where patients don't necessarily come to the hospital as quickly as they possibly would if they were having ongoing excruciating chest pain. The other area where there's a delay in acute ischemic stroke identification happens to be in younger patients. And we see a rise in stroke in younger patients, especially in millennials, especially in women, where in fact there's less recognition of their symptoms and less rapid identification that it's an ongoing stroke. So it all starts with the neurologic examination. And this has been, throughout the world in different languages, this is emphasized, with the idea of what is a stroke. And the manifestations of a neurologic large vessel stroke include that of facial weakness, typically the lower face, arm or leg weakness, speech difficulty, and the emphasis of time. And we add to that the BFAST, which is the balance abnormalities, as well as eyesight abnormalities. Now to this FAST and BFAST, we also add other variations. If it's a posterior circulation stroke, for example, involving the vertebral artery or basilar artery, it may involve more problems associated with level of consciousness. They may be more confused. They may have more vertiginous type symptoms under the area of balance. In rare cases, especially in younger patients, they may actually present with a seizure that we've seen. We had a young patient who presented with a seizure, and it was a large ICA, carotid artery occlusion. He had been taken off his anticoagulation for a prosthetic mitral valve, and he actually had a very different presentation that bewildered the ER when he first presented. Again, also including patients who have persistent unresponsiveness after they've been resuscitated. So what's a real world scenario that we find? So in the cardiac world, very similar to what we've seen at Washington Hospital Center, is that you can have patients who are inpatients that have strokes. They could be on a step-down unit getting vital sign checks, but not necessarily vital neuro checks to those vital signs. So what does that mean? It means that they may not necessarily be vocal about what the deficits are. It may be something that's recognized by a family or something that's just recognized by a medical technologist who's doing the vitals. But it's important to do neuro checks while you're doing vital checks, especially for those patients who might have a cardiac thrombus or who might be in a step-down unit because they're at particular risk for thromboembolic problems. And then what about the patients who awake with a stroke or who heavily sedated? Very difficult to assess these patients because these patients, unfortunately, have other medications ongoing that cloud their neurologic exam. So they might be confused because they're receiving Versed or they're just waking up from general anesthesia. And then during ongoing cardiac procedures, especially electrophysiologic procedures or valvular or coronary procedures, they're being sedated. They don't necessarily have the ability to be examined during the periods of sedation, and they may wake up after these procedures with a stroke. So every 40 seconds, someone in the US has a stroke, up to 700,000 people. an estimated 6.6 million Americans 20 and older have had a stroke. And again, I just want to emphasize this again, is that we're seeing an increased incidence. This is from Ireland, a study that was done several years ago, correlating increased incidence of stroke in the young in Ireland associated with cannabis and different toxins in the cannabis. And we're also seeing an increased incidence of stroke, although it's a delayed presentation associated with COVID infections. So if we look at the millennials in particular, and young millennials throughout the nation, we're seeing an increased incidence of stroke, in particular in the area of the Midwest as well as in the South, but it's also in areas of the Northeast. And this probably correlates with an increased incidence of hypertension, diabetes, and obesity as well, and other risk factors. So going back to the original change in our paradigm of managing stroke, we went from heroic efforts to actually controlled prospective randomized studies that supported the use of thrombectomy. And these were sort of the original 5 studies. And these studies were wrapped up mainly in the treatment of stroke for patients under 6 hours. So if we look at it in the cardiac patients in particular that we see the risk factors, AFib is probably one of the greatest. This is also followed by those patients, younger patients, who have associated heart abnormalities and or valvular abnormalities, and this is their initial presentation. It's important to realize, many of the patients that you're seeing for their cardiac abnormalities are the ones that we may see later for a thrombectomy. And these are the ones who are at highest risk for a stroke. So if they present with a cardiac event, or if they have an atrial appendage or mural thrombus or valvular abnormalities, those set them up for risk factors for a stroke, especially those involving the mitral valve, aortic abnormalities, and left ventricular thrombi. The other areas where we see the source for intracranial strokes can be that of carotid disease and what we call tandem occlusions, occlusions of both the carotid artery and then an acute occlusion of the middle cerebral artery. So these are occlusions that can occur with a dissection in younger patients or in older patients with associated carotid occlusive disease with carotid stenosis. In these cases, it becomes very challenging because to get to the target, you have to first open the cervical carotid artery to then get to the distal middle cerebral clot in the proximal portion of the middle cerebral artery to then open that and improve revascularization. So in these patients, we're using a combination of therapy, such as the aspiration with a stent triever of the distal clot, and then proximally angioplasty and sometimes stenting as well. So what about a stroke during a cardiac catheterization? So this is sort of the worst case type scenarios that we'll talk about. The best way to manage this is to call a code 1. So call code 1, call the neuro IR team, give us a heads up. And usually you'll be able to detect that the patient has a stroke because they have these findings of impaired neurologic examination, a paralysis of one side of the body, problems associated with speech, and they may even have gaze deviation where they're looking towards that side of the stroke. It's important if these cases already have an arterial sheath in place to leave it in place, because we can use that for access for our thrombectomy and not to remove it. They actually may have a decreased level of consciousness and have airway compromise, and they may need to be intubated. So the need to call for a code airway is also critical to ensure that their IV is working, because we want to avoid hypotension, hypoperfusion as well. So we don't know if that patient's stroke is because of ischemia, a blockage of blood flow, or maybe they've had a hemorrhage of the brain. So this is where we need imaging. And what the imaging does is threefold. It tells us whether it's an ischemic stroke or hemorrhagic stroke. It tells us whether the stroke is associated with a large vessel occlusion or a small vessel. And using the RAPID software, which we'll talk about here shortly, it tells us whether the penumbra, the tissue at risk, is larger than the core of the infarct. Okay, what's the worst case scenario? Well, worst case scenarios is where we have vitals being done but no neuro checks, a delay in detection, and no exam because the patient's heavily sedated or under anesthesia. And the patient may be in a situation where they're not monitored when they have this stroke. So let's say that the vitals are Q4 hours, or they're in that window of between vitals, and they have this ongoing stroke and nobody sees it. So that's one problem. Then the other set of problems is where we have a delay in activation. Delay in activation is because the code 1 is not immediately called. the nurse or the APC or the PA feels impelled to go through the regular staff, the house staff, or the regular team assigned to that patient, opposed to calling a code 1, and there's delay in activation. Or they thought, well, this patient we think is too far out beyond the window for treatment because we can't time the stroke. Again, that's something we're not going to know until we do imaging, because it's really the imaging, it's the tissue clock that tells us whether the patient's candidate or not, given that it's a ischemic stroke. Or that you've been paging the primary team or the surgeon, if it's a cardiothoracic surgeon or vascular surgeon, before you call the code 1. So what this does, it creates this scenario of what I call the triple effects of a poor outcome. It's a delay in detection, it's a delay in intervention, and it's a failure to anticipate. Whereas what we try to do is just the opposite. We want an early warning system. We want rapid intervention that includes rapid imaging and then rapid neurothrombectomy. And then we want a prevention of this ultimately so we don't have to go down this road. Secondary insults to injury, what I call, include that of where the airway becomes compromised and the patient is hypoxic, or the patient is hypotensive, because then they have also a concomitant cardiac event as well. Other problems is that the patient has a stroke, yet we take out the femoral sheath and we lose time in terms of access, or they have ongoing bleeding from a femoral hematoma and possible hypotension that can actually lead to a worse effect. If we go to what happened in the years after 2015 till now, we saw an increase of this window through the DAWN and DIFFUSE trials. This is part of the DIFFUSE trial where we established this rapid imaging. And the rapid imaging, what you're seeing over here is the pink, which is the core, and the green, which is the Penumbra, to establish basically this mismatch. So the mismatch here between a core of 23 and a mismatch of a volume of 128 was that you had a 5.6 volumes higher tissue at risk. So this is all the tissue that can become dead if you don't do the thrombectomy. So again, we're emphasizing the importance of time, and that's where these slides come in. These are the standards that we aspire to. These are the standards for emergent large vessel occlusion thrombectomy from our societies, from the door to physician evaluation. These are from outside, patients coming through the ER, and then getting imaged, and then the image being interpreted, and then the patient getting TPA. The goal basically is imaging within an interpretation with under 45 minutes, and then getting TPA within less than an hour. And then in terms of door to puncture time, getting the door to puncture time under 60 minutes, and then door to recanalization under 90 minutes. And that's a big challenge, to take somebody who comes from home, to evaluate them for a stroke, to get them stable from an IV airway standpoint, to then get them imaged from a CTA, CT perfusion, or MRI, MR perfusion standpoint, and then to get your thrombectomy team in place to do emergent thrombectomy, especially if it's at nights, on weekends, or holiday. But that's what our goal is to try to accelerate that. When you're in the procedure, from our standpoint, a technical standpoint, the quicker we're successful, the better the outcomes are. And that makes sense. If you're dealing with a soft thrombus where you can aspirate that clot like a little vacuum cleaner and get it done within 15 minutes, our outcomes are on the approximation of 50% return to normal. Whereas if you look at the extreme, where it takes you an hour or more to basically open up that vessel, our likelihood for a good outcome is on the order of 25% or less. So again, the time it takes us during our part of the procedure is related to the technical complications and difficulty of the patient's anatomy, as well as the underlying thrombus. We don't have imaging that tells us whether that thrombus is a soft red blood cell clot, or if that thrombus is a platelet-rich clot, or if it's an underlying intracranial atherosclerotic lesion, which is much more difficult to handle because that involves creating more support to then get into the vessel and then do a microangioplasty without rupturing the vessel. A very different entity for us than it is for the heart. So in the best case scenario, we have this great world where there's no delay in detection, there's no delay in imaging, and there's no delay in treatment. So there's no friction, there's no fog of war, there's no delay. I use a lot of military analogies given on my 31 years in the military. So this relies on you guys who are at the point of the spear, right there at the patient's bedside to be able to do neuro checks, be able to identify that there's an abnormality in the BFAST criteria, if there's problems associated with balance, eye movements, facial movement, arm weakness, or speech, and understand the essence of time. Call a code 1. Early imaging is being done, so there's no delay. Sometimes delay in imaging occurs because patient may have hypotension or an airway compromise, or they may not be stable or not be able to undergo an MRI because of a non-MRI compatible cardiac prosthetic. And then we confirm that large vessel occlusion. We confirm that there's a significant mismatch. Again, a small core, a large penumbra. And then we don't create secondary insult. There's no hypoxia, there's no hypotension. So now what we'll do is we'll go on to some real life cases. This is one such case, a 53-year-old male who was admitted with heart failure, who had a cardiac thrombus in the left ventricle, and he was undergoing bridge therapy to Coumadin, and I think he was on Lovenox at the time. He was found by the nurse a little bit past midnight, about 12:30 a.m. The last known normal was at 10:30. CTA was done about a half an hour later. He was agitated, confused. His exam showed a gaze palsy, a visual deficit, a facial paralysis, left arm weakness, some left leg weakness, and slurring of words. And he was more confused. Based on his history, he was at high risk. He had multiple comorbidities, AFib, intracardiac thrombus, HIV, pancreatitis, aortic valve replacement, mitral valve replacement. And again, he was on this therapeutic Lovenox bridge, Coumadin, other risk factors as well in terms of toxin abuse and smoking. What we found on his CTA was that the anterior circulation was open, but the top of the basilar artery was occluded. So that accounts for his confusion. So he immediately was intubated because it was a posterior circulation stroke involving a large vessel to the brainstem. We then took him to the IR suite in neurointerventional. We did an angiogram, and we could see that there was non-filling here of the top of the basilar. And so the basilar artery, which feeds the brainstem, is incredibly important. He didn't have adequate collateral circulation, and the clot that had come from his heart was now lodged into this area of the top of the basilar artery. So this leads to, if not death in 90% of cases, those who survive that tend to be locked into a comatose state. In fact, the diving bell and the butterfly, this is what happened to the editor for, I think it was the Fashion Magazine Bell, Fashion Magazine in France back in 1997. So that we're able to get our microcatheter up past the occlusion, open up the vessel that was affected. This is the distal vessel. And then with a combination of both the stentriever and aspiration, progressively suction aspirate the clot out until we completely open the vessel and restore normal blood flow to the basilar artery into the brainstem. So here's another situation which is probably much more relevant today. This is a lady who has a cough. She's been coughing for the past 2 weeks. She has a pneumonia. We don't know what her COVID status is. She shows up at the emergency room with a paralysis involving her left arm, left leg, as well as slurring of her words. Very large person, morbidly obese, hypertensive diabetic. And because of the COVID status, we want to prevent aerosolization of the virus. So we have this patient intubated. We prefer to have the patient intubated before they come into the IR suite to prevent the whole room from becoming contaminated with aerosolized virus. We do have a negative pressure room in the ER where it's better to actually have these patients intubated. And we then gain access. This is one of my colleagues' cases, Dr. Mai, and his first angiogram shows evidence of an occlusion of the carotid artery where there's a blockage of blood flow right at the skull base, and you can see no flow into the brain at all. So this is a huge risk to that hemisphere. He was able to open up the portion of the proximal portion of the carotid artery, restore some blood flow to the anterior cerebral artery, as you can see here in this film. And this is the tissue that was at risk. And then with multiple additional attempts, he was able to open up the entire circulation and restore, if you go back here, restore blood flow to the middle cerebral artery. And here it is, again, the tissue that's at risk, that's the whole penumbra. It's hard to see where the clot is itself, but you see where the blockage of blood flow is. Basically, blood flow stops right in that portion of the middle cerebral artery. And here's the anterior cerebral artery, which is trying to provide blood flow to that area that's ischemic. And then this is after he was successful with 3 passes. And this patient got completely better. I mean, she totally recovered from her stroke and from her pneumonia. Truly a remarkable event when you consider a patient with a stroke with COVID. And then this is the final result. Again, completely open circulation, demonstrated on the lateral as well as on the AP view. So we don't necessarily know where these clots are. Sometimes these clots migrate in the middle cerebral artery distribution. Here the clot is migrating basically out from the middle cerebral artery into different branches. So we get this cutoff sign, and that's sort of what it looks like radiographically. The clot is in these distal areas, but we don't know what the configuration of that is. Here it's sort of more straight, like a trident. Here it's a very, very tight downward curve. And so as we move our microcatheter, we feel that, and we're very, very delicate and very in tune so we don't cause a vessel damage or rupture. So here's one such case. This is the area of ischemia that you see here, so an absence of blood flow, and the clot is further out in the circulation. So this shows a microcatheter with the stent-triever navigated way out into that area of the circulation. First thing we do is that we get our microcatheter out into the vessel suspect. We do a microangiogram, then we deploy our stent-triever, wait approximately 5 minutes, and then aspirate it back. As we aspirate back, you see here, and we're pulling it back, you see the aspiration catheter, which will then move up into the area of the middle cerebral artery. So we're suctioning as well as we're pulling back the stent-triever so that we don't have distal emboli that go elsewhere. So this is what it looks like during the procedure. Here's the clot. So you see this sort of tapering off of the vessel right by the arrow. And then this is actually the stent-triever, which is out in that distal circulation. So we call this an M2, M3 branch. And we don't usually go beyond that. But it's creating a large area of tissue ischemia. And that tissue ischemia is very important because that's what is where the motor strip is. So that's the reason why this patient has a paralysis. So again, this is navigation of that microcatheter out into that distribution. This is from a frontal plane. These patients are under general anesthesia. We don't want them moving their head or neck around. And we're doing fine movements of the microcatheter out into this area. And so we don't want to perforate the vessel and avoid patient movement. And then this is after the revascularization process, after the stent-triever, after the aspiration. And you'll see a normal circulation pattern filling all those normal distal branches that previously had that whiteout, that gap. So other times we don't necessarily need to use a stent-triever. Here's an example where the blockage in the middle cerebral artery, we're able to aspirate it directly with this catheter. So if you look here, this is the outline of the catheter on the non-subtractive view. It makes all these twists and all these turns and goes right into the clot. And this is a very quick aspiration. This one was under 15 minutes, and the thrombus was sitting right here. With aspiration, we got complete revascularization. This is before, and then this is after. This is the AP after, and this is what it looked like before. Again, you can see a lot of robust collateral circulation coming in around from the surrounding vessels that help this patient be a candidate. Sometimes, though, it takes a lot more effort. This is a patient, again, who had what we call the TANDEM occlusion. The occlusion was in the carotid artery in the neck. We had to get through a very atherosclerotic plaque in the neck, angioplasty that, and then we got further distal. We opened up the middle cerebral artery, and then we went even further. We opened up what we call the M2 segment with a microcatheter. So you can see the area of significant wedge-shaped perfusion abnormality and a small core infarct. And this is the type of stent-triever we use called embotrap in this area. This is, again, the area that was at risk. And then this is the area post-embolectomy that we were then able to revascularize. This whole hemisphere was initially at risk. We got, again, in stages, first the cervical carotid, then the distal carotid, then the middle cerebral proximally, and then the middle cerebral distally. So these different segments of the middle cerebral artery are more prone for risk for rupture and injury as you go further out. So we typically try to stay proximal to the M2-3 segment. As you go out cortically, they're very, very fine filamentous branches, which are not good to put your stent tubular in. Here's another cardiac patient that got presented to us, a patient with a history of AFib, hypertension. She has severe coughing. She was noted to be acting different by her family. They brought her in after being at an outside hospital where she received TPA. She had basically a left gaze preference. And so what she's doing is she's staring at basically the left side, left hemisphere, which is where her infarct was. She was aphasic. She had no movement on the right side, and she became severely obtunded. She had a recent pneumonia and obesity, and became also what we call a person of interest, a person under investigation, rather, PUI, for possible COVID as well. Again, in her case, we see an occlusion with no filling of the carotid artery in the neck. So we had to get through this occlusion of the carotid artery in the neck first. We're able to get through the occlusion of the carotid artery in the neck, and then we see no blood filling in the carotid artery in the brain. We then have to do this in a series of stages. We open up that vessel in the brain. We get the catheter distal to the clot. We see more clot in the middle cerebral artery. So as we go through this in a series of different stages, we're progressively opening this up. It also turned out that she had an unruptured associated aneurysm. So we didn't know that until we got blood flow into the circulation. You can see here's the aneurysm. So we got the circulation open except for this division, which is occluded. In that division, we then catheterize in a separate stage using, once we had our access catheters up into this region, a microcatheter and then the embo trap. And then once we're able to open up that, we have what we call TICI-3 flow. This is a patient who flew into us from Reston. This is the timeline of treatment, lasting normal at 15:10, and it was completely open and revascularized by 19:20. So that's actually pretty good. That's under 6 hours. We like to do better than that, but this involved basically this patient being medevaced here, this patient being intubated, and this patient then also undergoing the CTA scan preoperatively. This is some of the clot that we pulled out. This is what I was talking about before, this very tenacious white clot or platelet-rich, fibrin-rich clot. She had a mix of that as well as this chunks of additional clot, and that was also combined with red clot. But this tends to be a very, very tenacious clot, much more difficult to aspirate out and remove compared to red blood cell clot. So here's one of our last examples, second to the end. This is a patient who was on the cardiac service. He had a cardiac thrombus, and he had basically been lasting normal at 8 a.m. He then, on follow-up examination, was noted to be aphasic and hemiplegic on his right side, although he was still following commands. He underwent an MRI that showed a large core. The core is almost 50 cc's, 41 cc's, but a much larger penumbra. So it was about 2.5, 2.4 cc deficit in terms of abnormality. So straight from MRI, we then took him to the neuro IR suite, finished around 12:45. And again, what we did is as soon as we did our angiogram, we saw this cutoff sign where he wasn't filling the carotid artery past the large PCOM artery. So we call this a carotid T occlusion. So it includes both the middle cerebral artery and the anterior cerebral artery. So not a lot of collaterals. Now, what was interesting about his particular case, because his cardiac status was so severe, we actually did him awake. He was a younger man in his 50s and was cooperative. So you'll see some head movement here. And again, this becomes a little bit more dangerous because you're moving microcatheters, micro wires in someone who's awake. But anesthesia was very concerned about the risk to his heart with putting him asleep, especially with this cardiac thrombus and very, very poor ejection fraction. So with that, we were able to get our microcatheter position. So here's the microcatheter now positioned in the middle cerebral artery. We've opened up this proximal portion. Here's our aspiration catheter. And then this is the deployment of the stent retriever. So again, it's a series of stages: femoral access, carotid artery access, open the carotid artery, aspiration catheter to the middle cerebral artery, and then further reach with the microcatheter into the distal middle cerebral artery and deploy the stent retriever. So here's a side view of that. Here's the stent retriever in place on a non-subtractive view. Here's the aspiration catheter. And so it's suctioning here and pulling the clot back in. And then this is pre, and then this is post embolectomy. So it's a very short middle cerebral artery segment. We don't know what the length of the middle cerebral artery segment is. We know that the aspiration catheter doesn't want to go past this bifurcation. So we follow this out with the microcatheter with the use of the stent retriever. And then this is, again, opening up the vessel, showing the normal middle cerebral artery distribution post-thrombectomy. And this is all the normal branches then filling throughout that entire hemisphere. And this was a very interesting case because the patient's awake, so literally on the table, he wakes up and he starts moving his right side and starts speaking again. It's very reassuring. This is a picture of his clot. Again, it's this combination of both this red blood cell rich dark clot as well as a fibrin rich white clot, which is part and parcel of what we find in these cases. And this is a stent retriever that we use. So this is a very specialized stent retriever. It's much better for these platelet-rich clots. It has this inner core to it and outer petals. So it grabs a hold of the clot and it doesn't allow emboli as much. This is a very interesting cardiac patient that got referred to us. This is actually a patient with an intra-aortic balloon pump. It was actually a subclavian balloon pump, which I had not seen before. It's, I guess, becoming much more common. And this is a patient who had the subclavian balloon pump and I think was being transitioned from different anticoagulation and was noted to have a new onset left hemiparesis and acute mental status after this placement of the subclavian balloon pump in the OR. So this balloon pump, I think, had just been placed. And her anti-stroke scale was very high. She was near comatose. She had significant significant cardiac dysfunction. So we couldn't really get to the target going transfemorally because she needed that balloon pump to serve to maintain her ejection fraction. And so it posed, unique challenges in terms of access. This is a case of Dr. Liu and Dr. Feldbaum's very unique situation. So she got all of her imaging done by 10:22. She also got IV TPA, and then she was in the neuro-IR suite by 10:22. She was intubated, put asleep. They started at 11:05, and they were done by 11:24. Very rapid case, and the ischemic time was only 2 hours and 33 minutes. And some of the challenges here is that normally we go transfemorally, or sometimes we'll go transradially, but in this case, you can't go with either because you have a subclavian balloon pump. So the balloon pump is blocking your normal guide catheters and aspiration catheters and long sheaths from coming up retrograde through the aorta, as well as your radial access would then come up through the subclavian, then go up into the carotid artery. So what they did was very novel. They did sort of an old school approach. They did a direct carotid stick. So here's an example of where the tip of the balloon catheter is. And so what they did is a direct carotid stick to revascularize this right MCA. So this is the core of the MCA. The core is down to 20, but the area of ischemia is much, much larger. It's almost 10 times larger. We're talking about a ratio of 9.6. So this whole hemisphere is at risk. They did a direct carotid stick using ultrasound. This is their micro wire. They placed their sheath then into the common carotid. They then did an angiogram through their common carotid injection. They got the aspiration catheter, no stent retriever, just direct aspiration. And they literally had, from the time that they did their carotid stick to their aspiration, on the order of 10 minutes, about 11 minutes, complete TICI-3 revascularization. They then held pressure for the carotid compression. So basically, I just want to conclude now and just emphasize that, it's not the idea that we're going to all of a sudden have this capability if we don't practice this every day. And the emphasis that we make in the military is that you train the way you fight and you're prepared at all times to do your very best. And the idea is that, we want to have early detection of these strokes that are both inpatients as well as outpatients, strokes that occur on the floor during a cardiac procedure or strokes that occur waking up from anesthesia. We want to be having early activation of the team, and as soon as the neurologists usually get the call for code 1 and they think that they have a large vessel occlusion, they usually give us a call and a heads up, just early warning, so we can activate the team, especially if it's after hours or on a weekend. And then we want to be able to rapidly image that patient. If the patient can't undergo an MRI, then we'll rapidly image that patient with a CT scan, CTA scan. And RAPID is actually the name of the software that looks at computerized perfusion versus the core versus perfusion abnormality. And then rapid revascularization, and that's really on us in terms of what we can do. We look at our cases, we look how we can improve outcomes in these patients by decreasing our time of the procedure, improving the revascularization in terms of TICI-3 flow, and preventing any injury. And then ultimately the goal is the best outcomes as a result. Well, that's all I have. Thank you guys for your time, and I'll take any questions if anybody has any questions about what we've talked about.
Thanks so much, Rocco. I think that was a great talk, and as the point, one of the points that I got from it certainly is that we share the patient population, right? Our patients are at high risk to develop this complication, and I know we work together. If anybody wants to ask questions, please unmute yourself, and Ron, I see you're ready, so why don't you start?
Yeah, thank you. This is a great series of cases and so much opportunities. I'd like to focus on maybe vertebral embolization into vertebra. Often we see it a lot with cardiac catheterization as one of the complications that I don't know how much you can offer there. And my second question about anticoagulation, we turn to use more and more Cangalor for patients who are coming with an acute MI to restore the flow without recurrent of thrombosis. So can you share with me any experience that you have?
Oh, absolutely. Yeah, you know, Cangalor, I think you guys had introduced us to Cangalor a year or 2 years ago. And so when we see these patients with these tandem occlusions where it's underlying atherosclerotic lesions and not just a soft thrombus, there's probably a role for Cangalor in those cases, especially when they have this tandem occlusion with a bad atherosclerotic lesion in the neck and a distal emboli. So I think in some of these cases, we've used Cangalor very selectively after we've actually angioplastied or as we're angioplasting the lesion, and then if we have an intracranial atherosclerotic lesion. So the problem with Cangalor for us is it takes a while to get from the pharmacy. It is very specific dosing, and our biggest fear is the risk for a reperfusion hemorrhage. That now we've opened up the vessel, you have this core of the brain that's already infarcted, so the blood-brain barrier may have been affected. And if that volume is too great, we worry about the Cangalor leading to a bleed. So that's been one of our concerns. But I think we're talking more and more about the use of Cangalor, especially for those cases that we get into, and it turns out to be an underlying intracranial atherosclerotic lesion, ICAT. Or if it's a lesion that we see that we get revascularization, but there's platelet accumulation, and seeing how the platelets dissolve with Cangalor is very effective.
But you give it systemically the same way that we give it, right?
Yeah. In terms of your question with the vertebral artery, I think the vertebral artery in posterior circulation stroke is very similar to what we see with the carotid artery in tandem strokes, tandem occlusions. So the vertebral artery origin stenosis lesions that can then be the source for a basal artery occlusion, I think those probably, you know, we need to think more creatively about treating those. And those might be cases that are better treated, especially acutely, through a transradial approach, where you have better access to angioplasty and stent proximally, and then do a distal thrombectomy in those specific cases.
So you use the same tooling, it just the access would be different.
Yeah, access is different. I think, you know, our balloons are going to have to be different as well, because the vessel, the nominal diameter of the vessel is going to be different. If you place a stent, which many of these cases you do, your placement of the stent has to be different. I think the vertebral artery origin stenosis or vertebral artery occlusions are very challenging for that reason.
And maybe I would ask you one question. It's more kind of political, not so much in this institution, because you guys do a terrific job and always ready for any intervention. But as you know, there is a a huge interest of interventional cardiologists to do acute stroke intervention, and there is sort of a turf issue and training issue, but many interventionalists feel that the level of skills that they need to get there is not that far. What are your thoughts about adding that to the interventional cardiology skills?
You know, that's a great discussion, you know, and we have this discussion every year at the CRT. And I think, you know, if you're a cardiologist who's routinely doing carotid angioplasty and stenting, you really should know the techniques of neurothrombectomy, because you might be in a situation where you're doing a carotid angioplasty and stent, and you need to be able to do your own neurovascular rescue, especially if you're at a smaller institution or you're in a remote institution. I think it takes a very specific amount of education, not just a knowledge of the anatomy, knowing the different variations of the MCA and ACA and intracranial circulation, but also the manipulation of the microcatheters and microwires is a little bit different in terms of, you know, the tactile kinetic feedback. You know, the risk for injury is higher. Problems that we have with the intracranial circulation can be, you know, a little bit more pronounced. Creating that support for angioplasty or thrombectomy depends upon the tortuosity of the anatomy and what proximal, you know, guide sheaths you have. But I don't think it's unreasonable for someone who's doing carotid angioplasty and stenting, but I think it's a unique cardiologist who's going to want to do that, because a lot of these cases, there's the challenge of the technical aspect of the procedure, but another big challenge is which patients are going to benefit. And that's a balance for us many a times based on the imaging and based on the patient's comorbidities. Because you can make a picture look better, but that doesn't necessarily make a patient look better. And in many of these cases, it might be that the patient is not going to benefit because the damage is already done, that the imaging that you got for the core and the penumbra is from several hours ago, and they've gone on to have, you know, persistent infarction, and then you convert it to a hemorrhagic stroke. So I think it's a little bit difficult because, you know, in that situation, if you're not doing a lot of thrombectomies, you know, if you're not doing a fair number of intracranial thrombectomies and you're doing it in the worst case scenario, that might not be the situation where you want to learn how to do it. So.
Yeah. The paradox is that those who wants to do it because there is no access to neurointerventionalists, skillful as you are coming from centers that they don't have much experience in doing carotid stenting. So their level of skills is far from, I mean, they really have to go through a lot of training to do that. And one thing people don't appreciate, you do one wrong movement with a wire, you're going to perforate and it's going to be disaster. So
that's right. And these, you know, these vessels, you're not seeing the vessel. It's a blind procedure because the clot prevents the vessel from filling with contrast. So you're passing wires and microcatheters into circulation you can't see, but you feel. And so that's right. That's an increased setup for perforation.
Thank you.
Can you talk a little bit about anticoagulation and reperfusion injury? As you mentioned, many of these patients you showed heparin, warfarin, DOACs, maybe Cangalore. What's the risk of reperfusion injury, bleeding? How do you think about those things? How do you manage those things?
Yeah, that's a real challenge because, you know, they come in on a certain regimen of anticoagulation, and that usually prevents them from being candidates for TPA. So you've just revascularized them, and you want to get them back on their anticoagulation for their, you know, cardiac valve or their intraluminal thrombus, you know, the thrombus that they have in the mural thrombus and the ventricle or in the atrial appendage. And so usually what we do is we look at the role maybe short term for aspirin, but then putting them back on their anticoagulation within a 24-hour window. So anywhere from 12 to 24 hours, we're concerned about the risk for rehemorrhage. So we try to do some form of cranial imaging post-procedure on those patients, either right there on the table with a CT or a delayed MRI within 6 hours afterwards, and then a follow-up CT within 12 to 24. So we use a combination of imaging as well as why are they on the anticoagulant. If they're on the anticoagulant because they have, let's say, a cardiac thrombus, much higher risk, then those patients, we try to get them back on their anticoagulation as soon as possible once we've documented that they don't have a reperfusion hemorrhage.
Any other questions from the group? One last question for me. You showed 1 or 2 cases of either COVID positive or PUIs, and certainly in the lay literature as well as within the medical literature, there's concern about hypercoagulable states in these patients. What have you guys seen with COVID? Is that, you mentioned one thing is patients delaying their care and avoiding care, but on the other side, have you seen increased thrombotic events to the brain in these types of patients?
Yeah, so we've seen a sort of a spectrum. We don't have the volume of cases that they've seen at Mount Sinai in New York. And I think part of that was related to, in New York City, the population density is much greater. We're talking about 100,000 people per square mile there in Manhattan. So what we're seeing is that we're seeing patients who come into the hospital later, number one. It's a delay in presentation because people are avoiding the hospital. Number two, the patients with COVID and stroke tend to be younger. They tend to be under 50 for the most part. But I'm going to emphasize this. They're not healthy under 50. They have concomitant comorbidities. They have diabetes. They have hypertension. They have smoking. They have obesity. So these are not healthy under 50-year-olds. They're people who have significant comorbidities. And then last thing I would say is that the collective experience for us is that our stroke numbers are actually down amidst COVID, probably because of these logistic issues. But I think in the experience of other people is that patients do worse if they have COVID and a stroke. And it's been quantitated that the outcomes are up to 7 times worse than patients who don't have COVID. So I think a lot of these patients have other factors going on, be it, the activation of the inflammatory cycle and cytokine activation and the problems with concomitant pulmonary, renal, cardiac issues as well. That these are very sick patients and that despite us getting a TICI-3 revascularization, we're not seeing the outcomes clinically as you might expect. So I think that's the challenge. And there's another group of COVID patients that we see who present with brain hemorrhages and not ischemia, or patients who present with strokes. One of my partners had this recently, Dr. Mai. We talked about it today. Strokes associated with small vessel disease, multiple emboli, requiring a hemicraniectomy, taking off half the skull to decrease intracranial pressure because of massive strokes as a result. And that patient was only in her 30s, but had concomitant history of diabetes, peripheral vascular disease, obesity, and other problems.
Toby, you had a question?
Yeah, hi. I know interventionists like to get obsessed with their equipment, but you showed a slide that was interesting to me. I wanted to ask you about steam shaping mandrels. Yeah. Can you tell me a little bit more about that and which catheters you use and how you do your catheter shaping? Sure.
So typically nowadays, we're not in a place where we necessarily need to do as much catheter shaping because our micro wires are much more navigable. So steam shaping is something that we're doing a lot more for aneurysm access, for intracranial aneurysms, to try to get stable position of a microcatheter and an aneurysm. But our micro wires have really gotten much more advanced. So occasionally what we'll do is, let's say if we have to go through some tortuous anatomy, let's say to get into one of those M2 branches, where it trifurcates, to get into that tree, and we can't get the wire to go very well, we'll basically use heat. We'll put our mandrel inside the microcatheter, give it a little shape, wet it, and then a little heat shape, and then take out the mandrel, and then make sure that it's patent. But that tends to be more for microaneurysm catheterization. Our biggest problem in most of these cases is not microcatheter position. It's been more proximal problems, proximal stability. Not just arch problems, but problems with tortuosity above the arch, tortuosity in the carotid siphon with a pinching siphon where it's such a tight turn that making that turn of the catheter, the larger catheters around the ophthalmic artery, can become quite difficult. And you know, there's pluses and minuses to different tools we have. Sometimes we just can't get the aspiration catheter, the bigger large bore catheters around that turn. And then we use just the microcatheter and a stent retriever as a result. So I had a case this weekend. It was really tortuous anatomy. You know, I was contemplating going transradially, but it really had benefited us. He had terrible tortuous iliac anatomy. You get to a point where maybe I should just do a direct carotid access. But in some of these patients, you're worried about, you know, with them being on Xarelto and other anticoagulants, you know, doing a direct carotid access and the need for, you know, the creation of hematoma, airway compromise, and so forth. So,
but do you, just to go back to the shaping, do you use steam or do you use a heat gun? How do you actually do it?
So we have like a heat gun that we use, and what we do is we wet it so it doesn't peel, so that it stays lubricated. So it's dipped in saline, and then we use a heat gun to shape it. Yeah.
Thanks.
Excellent. Well, we're certainly over time. This was a great topic. Thanks so much, Dr. Armonda, for this great talk. Important for all of us to think about these patients and call code 1 quickly and get you guys involved early on in the course.
Great. You're welcome. Thank you.
Great. Take care.